have our optimist and the pessimist, Dr. Chaitra Jayadev and Dr. Jay Sheth. I request both of them to occupy their positions in the ring. Please.
Dr. Gopal Pillai, sir, you're the fence sitter for this session.
So, good morning everybody. First, I'd like to thank Dr. Guruprasad. I think he's made my life very easy. He already says reversal is possible and it's a useful sign. So, I just will quickly run through my slides, no financial disclosures, but we've all been so used to looking at CMT all these days. We've seen retinas which are really thick but with fairly good vision, and thin retinas with very poor vision as well. So we do need DRIL because it's a very useful sign. It is first described in 2012 in an RO meeting where they said that it is an important parameter when we're looking at center involving macular edema. And then on, they did say that this is a marker even for those with resolved diabetic macular edema to prognosticate. So they said that those patients with edema and DRIL had poorer outcomes as against those with resolved edema and no DRIL. So going on to literature, just to summarize, foveal DRIL is associated with a worse baseline visual acuity in patients with DME, worse predicted visual acuity at the end of treatment itself, reduced visual acuity even in those patients in which the edema is resolved. It correlates very well with macular capillary non-perfusion and the FAZ, which is an indication of the macular function. And it is associated with increasing severity of DR, especially proliferative diabetic retinopathy, and also with structural disruption even in the outer retina, that is the EZ and the ELM. So that was as far as macular edema goes. What about those patients in which we don't see macular edema but very early DR changes? Even in these patients, they saw associated with higher BMI, longer diabetes duration, and a greater likelihood in those patients with mild to moderate than in those with no visible DR. So this is one of their slides in which they have shown there is no macular edema, but you're still able to see DRIL. So DRIL reversal does happen, and importantly, it correlates with visual acuity. So this is one of the landmark papers which showed us the prediction of visual acuity using DRIL. What they saw was a 300 micron DRIL increase during 4 months, showed a one-line decrease. And when DRIL actually decreased at least 250 microns, there was a 75 to 78% increase in the visual improvement. So DRIL can resolve over time. Resolving DRIL is a good indicator of subsequent visual improvement, and decreasing DRIL presumably represents anatomical improvement. And the reversibility potential actually declines with increasing duration of DRIL. So this is another paper that shows the different types of DRIL reversal. They actually found A to E, wherein A represents absolutely normal baseline OCTs where there was no DRIL up till E. So the reversal pattern that they saw here, this is A in which there was no DRIL. These were early resolvers in which there was resolution of more than 50% of DRIL at the first or second visit, and it was stable or improved at the end of the study. With late resolvers, there was resolution in the third or fourth visit, and here again it remained stable or improved. And these were inconsistent ones, wherein the resolution was more than 50 at any point, but there was recurrence. And finally, the persistent ones in which they never showed any resolution of DRIL at any point of time despite the resolution of DME. So here the observations were with early and late resolution of DRIL, the vision improvement was definitely better. Non-resolvers, the vision was poor, and the greatest vision improvement was noted in eyes with no baseline DRIL. So this is an important which shows here that higher the base DRIL, the poorer the response to treatment. So this is one last study, the RILITE study, which shows that DRIL severity was maximum in fovea and least in the further scans, and the severity across all scans improved with treatment. And eyes with the most improvement also had the most improvement in DRIL. So we always wonder whether we can actually measure the DRIL. Yes, it is reproducible and also objective. So this is a paper that has shown that the reproducibility is pretty good. And important here is that we actually focus on the area where there is no DRIL and then trace these layers towards the foveal center. It's easier to identify. So these are some cases. Patient presented with 624 vision, and you can see that there is here disorganization, but with treatment you can see that the layers are well seen up till the fovea and good visual improvement as well. This is again another patient who presented waxing and waning disease with treatment, but finally settled with good visual acuity as the lines are seen quite well. So to conclude, DRIL is a robust biomarker for DME, for helps in detection and monitoring, management and tailoring of therapy, Prognostication. So drill affecting at least 50% of the 1 millimeter central retinal zone is associated with worse visual acuity in eyes with current or resolved edema. Thank you.
Dr. J.
Can we have the slides, please? Yeah. So good morning, everyone. First of all, thank you, Dr. Unni, for giving me an opportunity to play the devil's advocate here. So my topic is, does drill reversal happen and is it useful? So I am the pessimist over here. So we'll directly cut to an interesting case of a 65-year-old gentleman who was a known case of diabetic since 10 years. He presented with bilateral reduction of vision. His vision acuity was 6/9 in both the eyes with a normal anterior segment. On examination, he had presence of significant diabetic retinopathy changes, which on fluorescein angiography, there was presence of early neovascularization elsewhere in the right eye, and as well as there were few foci of NVEs in the left eye also. So he was diagnosed with presence of early PDR, and when we did an OCT for the patient, in the left eye, there was presence of drill in this area with presence of significant diabetic macular edema. And in the right eye, there was minimal drill present here with minimal edema. So based on the clinical findings, the patient was advised both eyes intravitreal bevacizumab with titrated PRP. However, the patient was lost to follow-up, and the patient came back again after a period of 10 months. So when he came back, he came with worsening of vision in both the eyes. So visual acuity actually dropped from 6/9 to 6/15. So, but on detailed evaluation of the OCT, I found that there was worsening of the diabetic macular edema. So this is the right eye when the patient presented at the current visit, but the drill had completely resolved in this location. So the drop in the visual acuity was because the vision had worsened. Even in the left eye, the drill that was present 10 months before in this area started resolving, but still the patient had a reduction in the visual acuity because of worsening of the DME. So this time we went ahead and gave him the injection as well as a PRP. And after a month's time, the drill started resolving in the left eye. But still the visual acuity did not improve because the DME was almost the same. Whereas in the right eye, the visual acuity started improving from 6/15 to 6/12 as the edema started improving. We went ahead and gave a second dose of injection in both the eyes. And after that second dose of injection, once the edema started coming down in the left eye, it is then that the visual acuity started improving and not because of drill reversal. So we'll just zoom in onto the images of the left eye first. So at baseline, the patient had drill in this location, which after a 10-month follow-up period, there was significant resolution in this area, but the vision worsened because the edema worsened. After the first dose of injection, the drill started resolving even further, but still the vision did not improve because the edema did not resolve. And after the second dose of injection, the drill started improving further, but this time the vision started responding better because the edema started improving. And even in the right eye, the drill that was present at the baseline, it improved and it vanished completely after a period of 10 months. But the patient had decrease in the visual acuity because of the edema that kept on worsening. And after the first dose of injection, since the edema started responding, the vision started improving. And after the second dose of injection, there was not much change in the visual acuity because the edema did not respond. So this is one of the papers where they actually correlated the visual acuity with the area of the FAZ. And they found that the occurrence of intraretinal cyst, drill length, and lens status was significantly correlated with the visual acuity in univariate analysis. However, when they did a multiple regression analysis, they did not find drill to be a significant OCT biomarker for visual acuity outcomes. So there are multiple challenges when it comes to drill. First is defining. Although it has been characterized by Sun as a lack of distinguishable borders between these layers, the definition actually lacks the accuracy that is necessary to detect such a non-feature reliably. The identification is made even more difficult because this disorganization may be there because of multiple other reasons, like presence of a cystoid macular edema or presence of hyperreflective foci. And each of these factors itself can affect the visual acuity. And identification also depends based on machine. So machines such as Spectralis, which has got a high signal to noise ratio, it will be much easier for us to identify this OCT feature as compared to other imaging modalities. Also, there is very high intra and inter-observer variability. The interpretation is also very different amongst different people. and the pathogenesis is still not very well defined. Some say it has got neurological pathogenesis, means loss of ganglion cell layers, but still there is lack of any histological documentation for that. Others say it is because of vascular ischemia, and they have correlated with an increase in the FAZ size. So what can explain the reversal? Maybe because of reperfusion, but still there is lack of documentation. So everything is just a speculation, a hypothesis when it comes to drill. So if you ask me, does drill reversal happen? Yes, it may. But is it useful? I have my own reservations, because there are multiple difficulties and controversies in defining drill, and drill has not yet been sufficiently characterized by the use of traditional approaches to allow its standardized assessment. Thank you.
Thank you very much. Thank you very much. So both presenters have had a wonderful debate. So drill, what is drill? Drill is basically disorganization of the inner retinal layers. So that means that the transmission of impulses or whatever transformation of all these from the photoreceptors right to the ganglion cells is basically damaged. And they say it's basically the hyper elongation of the bipolar cells which actually break the process. And that is the reason why the functional element is reduced. Now the first problem is about identification of drill, as Guruprasad sir said and you had said. So large cystoid space can sometimes be mistook for a drill, and so the thin inner layers can be mistook. And these are usually chronic, and so we know that the large cystoid space may be difficult to reduce in size, and that may be one reason why the drill is not reversing. So the other problem is whenever drill occurs, there is disorganization, and if there is a resolution, the foveal thickness significantly reduces. And foveal atrophy, we know, is a condition in which there is significant poor prognosis in terms of functional visual acuity. So these challenges are there. So in all your pictures, I could see a lot of hyperreflective spots, a lot of other biomarkers which are also there. So if we take drill as a single thing, probably if drill reversibility occurs in some cases, definitely there's going to be improvement. Like in an ischemic retina, even if there is a reduction in edema, there's going to be benefit, but the benefit is not going to be as huge as in a case where there is no drill. Whereas in some cases in which the large cystoid space or so-called inner retina is completely disorganized, it doesn't come back, and that may be the reason why it is not happening. We also did one small study of about 40 patients. We looked at about 4 or 5 patients with drill, and we found that some patients are improving, some patients are not improving. So the whole thing is divided. I am not able to actually say that drill per se is a sign which will, because there are a lot of other factors involved in that. And one more thing, we did one cytokine study on drill. Just as I said, in high reflective spot, it was about IL-8 and MCP-1. Here, IL-6 was 10 times that of the non-drill patients. Thank you.
Thank you. Actually, it was very interesting in the sense that Jay split it further. So he showed patients where the edema persisted but drill resolved, and then said like vision is not improving. So who is right, who is wrong? Yeah, Dr. Parveen, you want to say something?
No, I just wanted to probably, whether we are missing something in the definition of drill. I think there should be an element of chronicity, or that you measure drill when the edema is less than 300 or 400 micron. In presence of a 500, 600 micron of macular thickness, can you really measure drill?
So I think you've summarized the problem. So drill's an optical phenomenon where you're not seeing the layers, and the layers depend on the alignment of highly reflective cells in the inner retina. Anything that disrupts it will cause drill. And that could be a chronic phenomenon like capillary dropout in diabetic macular ischemia that we assume is irreversible, and then drill's just a proxy for that. Or it could be an acute event. We saw images of retinal vein occlusions where you'd have drill because inner retinal edema with an acute ischemic event means you can't see the layers, where that will then resolve with thinning. And then there's disruption due to macular edema and local leak. So all of those could disrupt your layers, and then it depends on looking at the context and a temporal element, which makes it clinically slightly difficult. Just to throw it up there, any other thoughts from the panel?
So within 15 days of vein occlusion, you can't say drill is present. So,
well, it depends on how you define drill. If you can't see the inner retinal layers, is it disrupted or just loss of definition. So part of it is how we define it, and the definition needs to be reproducible and clinically applicable. I think we all have a gestalt as to what drill is, but which bits are reversible and which are irreversible, and whether doing that in the context of an angio-OCT of the macula to see the capillary dropout, whether that makes it more useful, I think we need to know more.
I think all the speakers and this discussion are all talking about, they start off with the same thing, that there is drill is disorganization of the inner layers. But then we lose the way. When you have cystoid spaces, you're going to have a compression of the layers. That's not the same thing as disorganization. Compression is going to be, the bigger the cystic spaces, the more the compression. The more the compression, the less your ability to predict whether this is reversible or not. So many of the cystic spaces will, once they go away or become less, what you're saying drill will go away, and you say drill is reversible. That's not drill. Either we differentiate that. Unless your definitions are very specific, you're going to get wrong answers. And that's what's happening here. If you consider drill in the presence of huge cystic spaces, you're actually misdiagnosing drill. But if you diagnose drill when you have minimal cystic spaces and now you can't see the layers, now you know that this is not going to be reversible. So you have two types of what you are calling drill. One which is not reversible, which is the solid kind of picture, not many cysts. That's not going to go away if the layers have not come back. But the ones with the cysts, the best way is do not define drill as during that period. And if it is only in the fovea, it has no value. If the cysts are beyond the fovea, then obviously that compression can go away and everything can reverse. So this is one. The second thing is the quality of the images. If you take stratus images, everything is drill. On the other hand, if you take the best quality images on Spectralis with clear media, you'd be able to say a lot of these which you're calling drill are not drill.
So I actually agree with everything that was just said. I have to confess that I have a bit of a bias because I don't look for this finding really anymore. And I have to say that the original Sun and Aiello description, the intention was really not to look for a reversible feature. They thought this was evidence of ischemia, and that was sort of the pre-OCT angiography days when we couldn't always get a sufficient quality fluorescein angiogram to assess the capillary perfusion. That problem has now disappeared. So the real question is, if you do an analysis where you include OCT angiography, you really have to see, just like the Freund paper, where they look to see, does it still stay in their multivariable model drill? That's what we need to determine. My suspicion is that in most cases, there won't be additional predictive value that the drill will add that we don't already get from other measures in OCT angiography. I will say, I'm guessing that. I don't know for sure because there could be other elements that drill captures beyond just ischemia.
Yes, so before the term drill, one of our PhD students, Dawnsin, did some OCT correlates with macular ischemia and showed localized slight thinning, but didn't describe the disruption. And it was just a proxy for where the capillary dropout was. And it didn't really add or do anything else, but it was a good way of saying, oh, actually, if I did an angio-OCT or a fluorescein, we could actually identify without the angio-OCT or the fluorescein where the capillary dropout is. So I kind of agree with the two previous comments that it's probably in the form without the macular edema just a proxy for it in most cases.
Thank you, Dr. Chaitra. Thank you, Dr. Jay. I think what we take forward here is like drill or not, make the edema go away, and drill is still a controversy whether you can define it appropriately.